clinical experience, and also we have the best evidence in terms of the reviews of clinical trials. The use of other non-invasive modes are less evidence-based, particularly the use of NIPPV and high flow, but I'd be happy during the course of the day to talk about those things. I'm going to focus more on the neonate with severe respiratory failure who needs to be intubated and ventilated, because I think often for clinicians that's where it gets very complicated. I know everyone here is very experienced already, and it's going to make it a much more interesting day if I don't do all the talking. It's going to be a lot better if you ask questions, and it's a lot more interesting for me, and it's going to serve you better if we talk about the issues that are most pertinent to you as a group or individual. So please feel free to interject and ask questions as you feel is appropriate. And if you want me to talk about a different topic, I'm happy to do so. I have a couple of lectures, one on conventional ventilation, one on the use of high frequency, and one on the use of how we identify our oxygen target. And we will do some practical demonstrations to hopefully reinforce some of those teaching points that I'll make. And I think essentially, apart from non-invasive ventilation, the advanced use of conventional modes, the decisions, and then the application to optimise high frequency, and then what oxygen you will target are the three decisions we make when we intubate a baby, and that's essentially what a ventilator provides now. So I hope that's what you're expecting today. Just bear with me for a minute. So I think part of the problem with conventional mechanical ventilation is that the machines are now too confusing. You know, when I started training in the early to mid 90s, it was pretty simple. You put a baby on conventional ventilation, and that was about it. And if you were lucky, you had a machine that would offer SI and B, but generally you didn't have any other options. And it's really been in the last 20 years that we've seen a rapid escalation in the number of modalities that are available on ventilators. And for many of us, I think this has made it harder, not easier, because we don't quite know what they all mean generally. And when we go and try to review the evidence, it becomes profoundly confusing. And for me, I think most of the clinical trials that have been done in conventional mechanical ventilation are an absolute waste of time, because they're not telling us how to use the ventilator properly for the baby's lungs. They're basically comparing one mode against the other, which is no different from doing a trial to decide whether you should buy Coke or Pepsi. It doesn't really tell you the fundamental question. It's just telling you stuff that's not that important. Because, and I'll talk a bit about this today, we can use fully synchronised mechanical ventilation with volume target ventilation, which combined would suggest in the randomised controlled trials that we're going to be the most lung protective if we do that. But we can do it in a way that is really quite injurious, even though the evidence would tell us that it's the best way to go. So it fundamentally comes down to not what mode you pick, but whether in your unit, your staff are firstly familiar with the mode, and you can apply conventional ventilation in a way that's going to optimise the care for the baby. And essentially, optimising the care for the baby means getting the best oxygenation, the best ventilation, and causing the least injury. The way you achieve that is not that important to me. What's more important is that you achieve those things, and that's what the baby wants. So I really want to spend most of this talk talking about not which mode we should pick. I'll go a little bit into that, but more about how we apply a mode once we've made that decision, and how we think about the baby physiologically because physiological-based application is really what we're doing at the bedside. If you, and I hope by the end of it, I will convince you that in your unit, if you say every baby goes on SIMV, every baby goes on a rate of 60 breaths a minute, every baby goes on an icon of 0.4 seconds, and every baby gets a target a tidal volume of 4 to 5 ml per kilo, that will be the wrong approach for many babies. So let's talk a little bit about the modes quickly. This should be a refresher. We know that the simplest mode is intermittent mechanical ventilation of CMV, and in that mode, essentially the ventilator delivers a PIP. You tell it when to deliver a PIP, you tell it how long to deliver a PIP, and between that it will deliver a PIP if you set it, and the ventilator does not worry at all about what the baby's doing. It's purely a slave for you and do exactly as you tell it. There are some advantages to doing that. It gives you full control, but there are significant disadvantages, particularly in an environment where we don't encourage babies now to be muscle relaxed and fully sedated, and we have endotracheal tubes which have leaks. I don't know what it's like for your practices here, but at least in Australia, this is the most commonly used mode. Would that be the case in Saudi?
Yes.
Yeah. And there's absolutely no reason for that. SIMV is the one that's been available for the longest, both in adult, paediatric and neonatal practice, and it's the one that's had the most investigations around it, and it is simple to use, it's fail-safe, it very rarely gets you into trouble. The nurses like it because it doesn't alarm as much as the other modes. Essentially here, you are telling the ventilator how many inflations it should try to synchronise with the patient. And I think you all know that. So that's the mandatory component. And the ventilator will attempt to synchronise those inflations. If the baby breathes less than the rate you've set, the ventilator gives unsynchronised or unsupported inflations to maintain a minimum mandatory minute ventilation. If the baby breathes more than that, then the baby will get no PIP support, which means that the baby is breathing itself against the PIP. And therein lies a potential difficulty with this mode, in that if a baby has a breathing rate above your mandatory rate, you are potentially exposing that baby to increased work of breathing and asynchrony in those inflations. If the baby is, so some people then set their SIMV rate very high, but that of course will mean that the baby is going to get less supported inflations or synchronised inflations. And that means that they're going to potentially be exposed to the effects of some degree of volume barrier trauma, even with volume targeting ventilation, which I'll show you. So but that's the limitations. The benefits are that when you get it right, it's very easy to use, and it's a very easy way to wean the baby off the ventilator. In the mid-90s to early 2000s, ventilator companies responded to the clinical criticism that in SIMV you potentially had a baby breathing against the ventilator with unsupported PIPs, and adapted their algorithms, which were already triggering, that's what SIMV does, to attempt to trigger every single inflation. And consequently, you now see that every ventilator has a different name for the same thing. And if you have more than one brand in your unit, it can be quite complicated. And we definitely see that in Australia with units with multiple ventilators and the staff not sure what all these different modes mean, and they come by different names. On the SLE, it's called patient triggered ventilation. On the VM500 and the Fabian, which I think are the three most commonly used conventional ventilators in the Ministry of Health, it's generally called assist control, unless you've asked the ventilator company to call it SIPVV. So synchronised intermittent positive pressure ventilation is the most commonly used term. And essentially here the ventilator is attempting to synchronise every breath that the baby takes, and you simply set an apnea or backup rate. If we want, we can talk about how to set that, because there's different approaches, but essentially you want to set your backup rate as slow as you can. The lower the backup rate, the more synchronisation you'll get. The problem is you don't want to set it too low, because the baby has prolonged periods of apnea or gets sedated for a procedure, the baby's CO2 may rise and may become hypoxic. Do you use pressure support much? Does anyone use pressure support? Yes, at the back there. Yeah. SIV with pressure support, yeah, which is a fantastic way to wean babies. We don't use it in acute disease, because in acute disease you may as well use SIPPV or patient-triggered ventilation, because in acute disease when you have active lung problems, every breath needs to give the same therapy, so we don't use it there. The advantage of SIV pressure support is particularly in weaning, where you can offer some pressure support inflations at a much lower PIP, so the baby's less likely to be hypocarbic. Pressure support ventilation is fully synchronised, but instead of being time cycle, it's flow cycle. And that gets everyone really confused, and people hate it because they don't know what flow cycling means, and they think, oh well, what does that? I don't really want to use something that sounds complicated. But essentially, it is the same as SIPDV. It synchronises the start of the inflation, but the ventilator analyses the flow wave to try to synchronise the end of the inflation. So both the commencement of breathing in and the commencement of breathing out become synchronised. So it is essentially a more advanced form of fully synchronisation, synchronised ventilation. And just like in SIPPV, you have a mandatory rate, and you want to set that such that the baby will breathe over that. In PSV, you have a mandatory maximum inspiratory time, because you don't want the baby to take a very, very, very long sustained inflation and hold its lung at PIP. So you tell the ventilator how long the TI can be, but the ventilator will then going to give a TI much shorter than that. So this mode is theoretically going to be the most lung protective, because it's synchronising into all facets of the respiratory cycle, especially if you're adding volume targeting. But it is the least commonly acute mode used to fully support a baby in ICU, mainly because as you increase complexity of synchronisation, you increase complexity for the user, and you increase the risk of there being alarms. And I think you then get a practical limitation to use. The biggest problem we find with this mode, which we don't mind in our unit, is that when you give babies complete control of their eye time, some babies hyperventilate. And theoretically, a baby can drop its eye time down to less than 0.1 second and just go and pant on the ventilator, and then they get into a lot of trouble. So that's usually the reason clinically you have to turn the mode off, because the baby hyperventilates. So I think because of those reasons and the lack of any large trial data to support that it's going to be better than any other mode, and we will never have that trial data now, people don't use it. Volume targeted ventilation, or some form of volume targeted type volume, and the correct term is volume targeted ventilation, because that includes all of the modes, VG, TTV, all of that in one umbrella, is not a mode you can use by itself. It's like buying an app for your iPhone. You have to have the iPhone first. So it can be added into any mode. You can add it into IMV if you wish. It doesn't have to be synchronised. And essentially here, you're telling the ventilator what type of volume to deliver, and it tries to work out the right PIP to do that. It is still time cycle and flow cycle pressure limited ventilation. It's not like in the adults where you have a true volume delivery system. It's basically, and I'll show you a representation, that it's essentially a way of the ventilator trying to adapt to the baby's own breathing effort and the changing algorithms. So putting it all together, all modes of conventional mechanical ventilation, and indeed all modes of high frequency, and arguably non-invasive ventilation if you use NIBPV or BiPAP, do the same thing. They have a period of time where PEP is applied, a period of time where PIP is applied. This is inflation, this is deflation. You have an I time and an E time, which together allow you to have a rate. And the difference between the modes are simply whether you initiate the I time, whether you terminate the I time, that's what pressure support is, and what sort of limit you provide on PIP, whether it's a fixed limit or whether you allow the PIP to be limited based on the volume response of the lung. I know this is basic, but it's worth going over it again because it allows us us to go back to our teams and talk to them about the fundamentals. I think we've, as a craft group, lost the fundamentals that we were being taught back in the 80s and 90s when ventilators were available, and this is all they did. Now we're so focused on the other stuff, we sometimes forget the basics. So whilst this is what we see at the bedside and the choices we need to make, the way the ventilator does it is always the same. The ventilators give a pressure to the lung, whether it's PIP or PEEP, and they do it by a constant flow of gas. And that's really important as you think about some of the different modes of ventilation. Sometimes it's appropriate to change that flow of gas, and as I'll show you with high frequency, different oscillators provide very different gas flows. We modulate or limit the pressure against time of flow. We allow the ventilator to actively inflate the lung. But expiration is passive. And again, that's a key fundamental that you need to make sure all of your staff understand. On a conventional mode, we are only allowing the ventilator only does something in inspiration. It allows the baby to do all the work in expiration, because the lung's natural state is to collapse. It's a big spring that wants to recoil. And we may or may not synchronise all or some of inflation, and we may or may not adapt the pressure to a constant higher volume. Of course, when we make those choices, in the back of our head should always be, will those choices cause harm? We don't ventilate babies to cause lung injury. We ventilate babies because they either have profound hypoxic respiratory failure and they need ventilation to oxygenate, a ventilator to oxygenate, or they have profound impairment of minute ventilation and they need a ventilator to control their CO2, which is rising, or a combination of both, which is often the case. We don't do it to injure them. Injuring chronic lung disease are the consequences of our need to intubate a baby. And this is why we should never intubate if we can't, if we can get away with it. Because as soon as you put a baby on a conventional ventilator, you are increasing their risk of lung injury. Every inflation a baby takes on positive pressure ventilation will cause some lung injury. So I've moved away from thinking about how do we cure or fix BPD to accepting that BPD will be a part of my life as a clinician and my patient's life, and my job is to modulate or minimise the risk of BPD. The difficulty for us is that we have lots of ways we can injure the lung. It's very easy to injure a preterm baby's lung. It makes it easy to do it. It makes it good for me as a medical researcher because I have lots of things I can try to fix, but it's not good for the babies. And where it becomes really complicated for lung injury is that there's no easy path. The pathway to lung protection, which I define as good oxygenation and good CO2 clearance with the least harm, that pathway is very narrow. If we steer the ship too far in one direction and make the lung and avoid volume trauma, we can split the lung into atelectasis. And an atelectatic lung, as I'll show you in some videos, is a lung that is also generating shear forces and getting mechanical injury occurring as well as just the biotrauma of atelectasis. If we swing away from atelectasis and apply a lot of pressure to the lung, we are going to expose it to volume trauma. There is barotrauma, but as most of you know, neonatologists don't believe that much in barotrauma anymore, but there is clearly barotrauma. And if we look at where the adults are moving in the ARDS field, they are very strongly now saying that it's actually the pressure that's causing a lot of harm, not just the volume. So we should accept both. If we have asynchrony between the patient and the ventilator, we're more likely to cause injury. And that's where synchronisation becomes more tricky. And all of that together causes a biological trauma and often then causes an increase in oxygen, as we all know oxygen is toxic as well. So it's very easy to cause injury. Back here in 1985 in France, there was a fundamental paper, a series of studies done in rabbits, adult rabbits with acute surfactant deficient disease. And this study is what has formulated the current approach to conventional ventilation and high frequency that we have been using in neonates for more than a generation now. And for your fellows and registrars, this should be a key paper to read, even though it's very old and it's not neonatal, because it's the philosophy behind how we ventilate. Because in this study they compared high and low peak and high and low tidal volumes and the injury response. And it was only with the combination of a high peak to overcome atelectasis, so not a high PIP, a high peak, so it's focusing on making sure atelectasis isn't a part of expiration, because it's in expiration you become atelectatic, it's in inspiration to recruit the lung. A high peak followed with a low tidal volume and therefore a low driving pressure, but you get the least expression of lung injury in these animals. And this is what we all try to do now, don't we? We've accepted high peak, low tidal volume. Putting a baby, a preterm baby in a peak of 6 to 8 centimetres of water and targeting a tidal volume of 4 to 5 ml per kilo is essentially this Dreyfus approach. So what are the ventilators trying to tell us? They give us the information we need. We get 3 waves, and it's important that this is part of the wardrobe to look at the waves on a ventilator. Because these waves, they're not sort of ventilator looks pretty. They're there to give us feedback on what we're doing. And they only really measure 2 things directly, apart from oxygen, that's the 3rd thing. They measure pressure and they measure flow, and then from the flow wave they integrate the volume that's being given. Obviously, the PIP is the peak in the pressure wave, the PEP is the trough in the pressure wave. And therefore, by definition, inspiration is occurring in the states here. So TI is when the PIP pressure starts to go up, and it ends when pressure starts to go down. And that correlates with an increase or positive change in our flow wave. And the flow wave is the most important wave, because it's telling us about the baby's lungs, not just about what we're doing to them. So here you can see positive flow, and that positive flow goes to 0 at the end of TI here in this wave. And this is what we expect, because flow is a measure of speed. So initially when the lung at end expiration starts inflating, the rate of change of volume in the lung is very, very quick. And then once the lung gets to full inflation, it can't move anymore, because the balloon's fully blown up inside the chest, and therefore the flow of gas should slow down and ultimately get back to 0. And then expiration is the reversal of that flow of gas. Once expiration starts, because the lungs speed spring and follows Hooke's law, it will recoil very quickly initially, gas will quickly move out of the lungs, you get a rapid decrease in flow, and then it should normalise again once all that lung has been emptied of gas. And then we have our VTI and our VTE, and in this case obviously we have no leak, because the end of VTE is back at 0 and the start of VTI is always at 0. The leak would be evident if the end of VTE did not get to 0. So here we can tell from these 3 ways what pressure we're giving, the way that pressure is going in, how the lung is responding to that pressure, which is what the flow wave does, whether the lung has enough time to inspire, inflate and then deflate, and whether we have a leak in the system by comparing the VTI and VTE. So everything we need to know if we're doing our ventilation correctly, except the blood gas. And then in fact, as I'll show you in the demonstration, this flow wave actually tells you how to interpret blood gas too. There are a lot of numeric descriptors which tell us about what's going on, but it's the waves that are the most important. So what about setting the I time and E time? Do you guys pick an I time for every baby, or do you have a standardised guideline for most preterm babies? When I was a trainee in Melbourne and I was doing transport, I was told at the start of my training by a very senior neonatologist that if you're picking a baby up and you're going to hospital A, I won't say which hospital, you put the I time at 0.35, because they put all babies at 0.35. If you're picking a baby up and taking it to hospital B, it's 0.5. because they did all babies at 0.5, because in the RCTs of eye times, that was the shortest eye time used in the RCTs, and the Cochrane meta-analysis shows that short eye time is better than a long eye time. If you're going to hospital C, you pick 0.4, because they're the hospital that doesn't fight with hospital A and hospital B, which are always fighting, so they always pick the middle ground between the two, so they're the compromised unit. And if you're going to hospital D, which was the complex unit I work in now, which is a referral surgical sort of complex ventilation unit, you pick the eye time that is physiologically appropriate for the time constant of the lung when you assess the baby prior to transfer. So, and as a trainee, you come out of that going, I don't know what to do now. So, and what does it mean to say it's physiologically appropriate for the time constant of the lung? That's a fancy way of saying not all babies have the same lungs, and you should pick your eye time based on the baby's lung disease and the shape and size of that baby. We know that when we apply a pressure to the lung, a PIP to the lung, the way lung volume changes, or your tidal volume that occurs, is very predictable. It follows this pattern, which, if you're mathematically inclined, is this. So if you really want to show off to your fellows, you can tell them that the tidal volume change in the lung is responding to this equation. It won't make you any friends, though. I've tried it. They just think you're strange. So, but what it means is that you have this exponential curve, which we've seen in medicine a lot. This is what happens when you prescribe drugs. If you give a dose of a drug, it takes 5 half-lives to get to a steady state. When you apply a PIP to the lung, it takes 5 half-lives for tidal volume to get to full tidal volume. But what's the half-life? The half-life is called the time constant of the lung. And the time constant of the lung is the time it takes for 63% of the tidal volume you want to get into the lung. So here you can see the problem. If you set 4 ml per kilo, or say you don't use volume targeting, you want the baby to get 10 mils of tidal volume, and you set your eye time too short, so if it's set to 1 time constant, only 6 mils of that 10 mil will get in. Even though you've asked it to do 10 mils or you want it to, it just can't get in if the eye time stopped. Once you stop the eye time, there's no more volume going into the lung. So if you're on volume targeted ventilation and you've set 10 mils and you set your eye time too short, the ventilator's going to give 6 mils and it's going to go, oh no, I was asked to give 10 mils. I'm not allowed to change the eye time because the eye time is determined by the doctor. So all I can do now is increase my PIP to try to get the volume in quicker. Because if you increase your PIP, this curve becomes really steep. So you may think you're being lung protected, but if your eye time is too short in volume targeting, the ventilator's giving much higher PIPs. And therefore you're actually preventing volume trauma by allowing the lung to be exposed to barrow trauma, which is not ideal. So that's the science behind it. And it's all well and good for me to say this is what happens, and this has been well known since the 50s, the 60s. This is actually the Salazar and Knowles equation, which defines how volume changes in the lung. How do we do that on the bedside? Because how do we know what eye time is set? Well, there's 2 ways. See what happens. Sometimes that's this.